right. Thank you so much. Where do I get my slides? Thank you, everyone. I know it's almost the end of the day, but hopefully we should be quick and fast with this. Can I get my slides, please? Oh, okay. Anybody wants to share a joke? So why do you trust your kids more than your wife? Because your wife is not a blood relation. Your kids are your blood. Okay. Oh, half of the people woke up later. Okay, it's fine. All right. Thank you for my talk. All right. So what we're going to talk about is a little bit about peripheral arterial disease. I know we do a lot of endovascular interventions. We at Sinai, if you don't know, we are like one of the busiest programs on the East Coast. We work in good conjunction with vascular surgery and IR, and with the guidance of PK there, and me and Raman and Guja and other people, we actually have built up a very substantiated program. So as some of the nurses who work with us, it's a pleasure working with you, and thank you for your support. So just to give you a brief overview what PAD is. So peripheral arterial disease is essentially a manifestation of your atherosclerotic cardiovascular disease. We see a lot of patients with CAD, but they also have concomitant PAD. So they should actually be managed pretty much in the same aggressive way as you would manage a patient who has coronary artery disease, especially if it's secondary prevention. The tricky part is PAD, almost 50% of the patients who have peripheral arterial disease are asymptomatic. So they're walking, talking around, and you would never know they have disease till the time you actually investigate further or ask a few extra questions. And most of the times, it's a stable disease with the rate of progression, meaning progressing into rest pain, ulcer, gangrene, is approximately 27%. So one of the important parameter markers, just to give you an overview of what we do, is an ABI, which we'll see in a lot of reports in the cath lab, which is essentially an ankle brachial index, where we measure the blood pressure cuffs, the blood pressure in your leg and your arm, and we do a simple mathematical calculation, which is division. We divide the ankle pressure by the highest arm pressure, and we get an interpretation of what it is. And this is the chart you're going to see is where you have ABI, which are different categories. Anywhere between 0.4 to 0.9 are mainly mild and moderate disease, patients presenting with claudication. Less than 0.4 is where you have rest pain, ulcer, gangrene starts. And the reason where ABI is very significant or critical is because there is a little bit of method to the madness. If ABI is bad, as you can see when your graph goes to the left, meaning your numbers start to go down, your chances of dying actually start to go up. So there is a real clinical significance of a patient who has poor ABI versus somebody who doesn't. And this was, I was talking about claudication or PAD being with the tip of iceberg, where most of the patients remain stable, but there are certain categories around 23 to 27% which actually go down the bad pathway. And if you leave these patients the way it is, actually their long-term survival is actually not good. If you look, they actually followed patients for 10 years, and you can see that the survival rate of these PAD patients just presenting with claudication is approximately 60%. And the major cause of their mortality is your myocardial infarction, which is the graph in yellow. You obviously have intervention and amputation playing a part, but the survival is horrible. And the worst survival is actually in patients who present with diabetes and who have PAD both. So if you look at the graph following the patients for 16 years, essentially 14 more, is patients who have the lowest, who have peripheral arterial disease and have diabetes have the worst outcome. If you're not a diabetic, not a PAD, your outcomes are still much better and then the rest lie in the middle. So what we're talking about PAD is the management. So the earliest of the trials were based on just balloon angioplasties. So any of those future trials you're going to see, they're going to compare what new device does versus the so-called standard of care, which was just balloon angioplasty. The problem with balloon angioplasty is your patency rate is horrible. If you read the literature, is around 37%, up and down range being like around 30s to 53%. If you go on the industry data, it's around 28%. So the patency rate of plain old balloon angioplasty really doesn't work. So if somebody is coming in with you with peripheral arterial disease, angiograms, significant stenosis of any of the arteries, just doing angioplasty doesn't really suffice. It doesn't give you good outcomes. The poor guy is going to come back in 6 months to 1 year with recurrence of signs and symptoms. So because of this concept is where all the technological advancements start to happen, of course, with the guidelines. So we're going to talk to a few things about what we do nowadays. So first category of devices. So we have atherectomy devices, which is essentially modification of your plaque or lesion. It's not a definitive therapy. Atherectomy is where you use devices where you clean the plaque up, increase the luminal gain, and then you want to decide whether I want to do a drug-coated balloon, which is a technology we use in peripheral, not in coronaries, or you want to put a stent in. So these are certain atherectomy devices that are available in the market. On the top left corner of you, you can see a directional atherectomy where you can actually move your catheters or based on the direction you like. You can go all 4 quadrants. This is pretty much what we do. The next one is your orbital atherectomy, which you have seen, which is it revolves around the orbit, which has diamond stud on it, and it actually debulks the lesion to give you more luminal gain. The bottom left is the laser. Again, another technology for your atherectomy. And then the last one is aspiration in addition to you doing your atherectomy objects. So this is one of the cases where for people for anatomical description, this is a patient who's presenting. This is the leftmost picture is essentially it's the left popliteal area. You can actually, you can actually see that this is the area that's missing. This is your posterior tibial and your peroneal artery, and the anterior tibial goes there. So what we did is just what we call as directional atherectomy. And you can see this is not even stenting. This is not even ballooning. It's debulked your lesion to improve the luminal gain and give you some better outflow. Of course, we have to have, because this is an adjunct therapy and not the primary treatment, we can do drug-coated balloon on stenting depending on the data I'm going to show you. And this is the plaque you can see down here, which is all the atherosclerotic fibrotic plaque you come out. And the trials that are based on these devices are pretty much like, especially in the directional atherectomy, is the definitive LE trial, which actually did 800 subjects with 47 centers. They did a eligibility criteria where you had to have more than 50% stenosis. And this is one of the classifications used to define atherectomy. And you can see most of the patients were claudicant and some had critical limb ischemia. So it was a good amount of patients. They actually followed up both, and they further divided them into diabetics and non-diabetics. And they followed up, and you can actually see if you do an atherectomy, especially in diabetics, small lesions, middle-level lesions, and long lesions, the patency rate is better in patients who will get atherectomy as compared to somebody who doesn't. And also based on the segment, if you're doing the SFA, if you're doing the popliteal, or if you do below the knee, the patency rate, meaning the chances the vessel remains open, are pretty significantly higher into the 70s and the early 80s percentage. Remember, balloon angioplasty, 37-40%. Atherectomy here is giving you primary patency around 77 to 85%, depending on your lesion location and the length of the lesion per se. And this, again, for patients who come with critical limb ischemia, we are able to salvage approximately 95% of the patients to make sure their vessels are open. But one of the latest technologies we are using right now is the drug-coated balloons. I'm sure you heard of them. They're like balloons which have a drug lining or coating. Right now, the only medication, so-called the drug approved, is Paclitaxel. So it pretty much sounds like we are back in the coronary era in like 2000s, where the bare metal had just finished, and we started with the Paclitaxel or Taxa stents, if people remember. So essentially, in the US, there are 4 of them which are available right now. It's the Lutonix balloon, if you hear, made by BD. They have the Impact balloon, which is made by Medtronic. You have the Stellarex balloon, which is made by Philips. And you have the Ranger balloon, which is made by Boston Scientific. So we talked about the balloon angioplasty. These are the different DCPs. So the way a drug-coated balloon is made is by 4 components. You have a balloon platform, which is where the balloon tracks on the vessel to deliver the drug. You have the anti-restenotic drug, which is, in this case, is Paclitaxel right now. They are testing the limus, the sirolimus, and the other limus medications in them. You have an excipient which actually attaches the drug to the balloon, so that way you can deliver it to the site you want it to deliver to. And then you, of course, have a coating material to give it a uniformity. So these are the 4 important structures for a drug-coated balloon balloon for somebody to know of. So one of the trials, just to give you an idea how the drug-coated balloon works and how good it is, I'm going to just give you an overview of what's happening with these trials and the technology per se. So the Levant 2 trial is for the Lutonix balloon. They have a 2-year data. And if you see the primary patency, initially they started at 1 year was 73% as compared to somebody who just got a balloon, which was around 56%. And the freedom from what we call as target lesion revascularization, meaning the chances that the patient is going to come back, the area you fixed is going to re-stenose and you need to refix it or recorrect it or do an intervention again in the same area. The freedom from that was actually much better in the balloon as compared to the other arm. At 2 years, the patency rate was not as good in this balloon per se, but it was still statistically significant, the p-value of 0.05%. So we talked about the coding part. And just to give you an overview, Paclitaxel, but they come in different drug dosage. You can see the Lutonix has a drug dose of 2 micrograms per millimeter squared. The Impact has 3 microgram per millimeter squared. The Ranger and the Lutonix, other ones have 2 to 3, and they have different excipients, a different way to bind the drug itself. The idea is for you to deliver the medication to the area to decrease the smooth muscle growth. So they actually followed the patients, did microgrowth, and they actually see at the end of 14 to 21 years, there was less remodeling and less smooth muscle growth as well. Talking about the Medtronic balloon, which is the Impact, there's actually good 5-year data now, which shows that at the end of 5 years, the balloon, the patients who receive balloon, their chances of freedom from clinically driven revascularization, meaning for them to come back and have an intervention, was much better in the balloon arm, which is in the red, as compared to plain old balloon angioplasty arm, which is good. That means the balloon is doing well and the vessel is responding well. This is just an overview of how they did it at 1 year, 2 year, 3 years, and 4 years. The Illuminate study was a similar study in the StellarX arm. Again, patient followed up for 5 years, randomized. And you can, this was actually, a single arm study where they just put the balloon in, followed those patients for 5 years. And you can see at the end of 4 years, their patency rate, meaning the vessel being open, was 75.6%. Again, to reinstate the fact that the drug-coated balloons do work, have a beneficial effect, and good patency rate. There was also no real difference initially from mortality or from survival. So that means the drug-coated balloon is not causing any harm. Remember, I'm sure you remember that there was a big controversy of how drug-coated balloons, one of the paper by Costanos said that the drug-coated balloon are actually killing people and increase mortality. But there were a lot of publications after that to rebuttal the whole thing. And this is a part of one of those publications which actually shows that if you use StellarX versus plain old balloon angioplasty, there's no difference in survival between the 5 years. This is the 4th balloon, the Ranger balloon by Philips. Again, another different excipient, different drug concentration. And this at 2 years also shows that there's an 84% primary patency, meaning the vessels are open 84% as compared to somebody who's getting a PTA arm. Whether it be the calcified group here, whether it be the complete total occlusion group, or even based on gender, the performance of the drug-coated balloon is significantly better as compared to somebody who's getting a plain old balloon angioplasty. So this was one of the first head-to-head where they actually compared one drug-coated balloon versus the other, because that was really commendable. Usually you want to compare it with a balloon angioplasty, look great, get your approval and make all the money, but these guys actually did a head-to-head comparison between the Ranger balloon and the Medtronic Impact balloon. And they actually showed that the Ranger balloon does a little bit better in a primary patency, even though not statistically different. You can see they were almost head-to-head at 1 year and at 2 years, so they did decently well. And the patency rate, however, was better in the Ranger arm, and as well as freedom from major adverse events was much better in the Ranger arm as compared to Impact arm. But overall, they did great. So drug-coated balloon, great technology, good indication. You're not putting a metal or a scaffold in, so at least the vessel is still so-called de novo. We didn't add any artificial metal to it. But sometimes you have to stent in peripherals. It's like in coronaries where the rough rule of thumb is you always end up stenting. You don't really do PTA. In peripherals, we can get away by doing drug-coated balloon and not put a stent in. But what about in patients who do need a stent? Now, if you're needing a stent, there are multiple issues that could deal with. Stenting is simple, quick, reasonable patency. The issue is you have a cost, you have a restenosis, and there's always a chance of stent fracture. So these are a few stents that are available overall. You can have a bare metal stent, which could be self-expanding, meaning you just deploy the stent and it expands by itself, or you have a regular balloon expandable stents, which we use in the coronaries as well, where you need a balloon to deploy the stent to the wall. You can also have covered and non-covered stents, meaning they have a cloth, a material, a PTFE graft to make sure if is it with it or without it. And then this is the newer, which is the drug-eluting stent. Two of them, which is the Silver PTX and the Illuvia stents are in the market right now, which has the same Paclitaxel, but now it's attached to the stent rather than the balloon in both the stents as well. And then the last one is a self-woven nitinol stent, which people know it as Supera. So it's a single wire stent where you have to actually create a stent. All the rest of the places, stent comes in, crimped on the balloon. All you got to do is, or in a sheath, all you got to do is just unfold it and deploy it. Stent is preformed. In Supera, you actually have to create a stent inside. So it's one wire, and you're supposed to do a good job. So just to give you an idea of how good the Silver is, again, nitinol stent, with a 3 microgram per millimeter Paclitaxel in it. But these stents also work great. Followed for 5 years, you can actually see when he compared the standard of care. So in this case, what they did is they divided 2 categories of patients. One will get the Silver PTX, which is the drug-coated stent. The other one will get a plain old balloon angioplasty. But what would happen if that balloon angioplasty part of the patient has a dissection or a flow-limiting lesion, meaning the vessel is so much shredded that there is no flow? Then it's unfair to compare the drug stent arm with the dissection or this flow-limiting. So in those cases, that category of patients who receive bare metal stent, they compared them with bare metal stent as well. So here you can see that Silver PTX, which is the red line, at 5 years has good freedom for target lesion revascularization. So they were 83.1% as compared to somebody who got a bare metal stent, which is 67.6%. For talking about purely the patency or how good the stent works, they actually follow the patient again with the standard of care. You can see 5 years, there's a significant difference between the two arms, the graph actually spreading out well, and so is the clinical benefit index. So consistently in all the fronts, whether it's target lesion revascularization, whether it be primary patency, whether it be just the clinical benefit, these stents are doing a great job in advancements as compared to who gets a balloon angioplasty. And if you do a bare metal stent, again, these stents provide good patency. So it's an excellent result following up all the way through 5 years. The other stent that's available in the market is the Illuvia stent, which is it's a same Paclitaxel stent, which had an eminent trial, which they compared the Illuvia stent to a bare metal stent, 2:1 randomized, 775 patients across Europe. And here you can see as well, at 1 year, the patency rate was better, 85.4% as compared to 76.3%, as well as sustained clinical improvement. The blue arm, which is the Illuvia, did much better than the bare metal stent. And this stent, what they did, like how the Ranger compared themselves to another drug-coated balloon, these guys also wanted to show themselves that they are better or at least equivalent or non-inferior to the Silver PTX, which was a first stent that was a drug-eluting stent. So what they did is they did a head-to-head trial between Illuvia stent and a Silver PTX stent. They followed them for 2 years, and they actually showed that the Illuvia stent has decreased failure and actually better results as compared to Silver PTX. So you can see the major adverse events are same. That means Illuvia is not causing more damage or more harm than Silver PTX, but it's actually the target lesion revascularization is much lower. So that means only 12% of the patients had to come back and get their stents fixed. Finishing up with talking about Supera stent, which I talked about, is the self-evolving nitinol stents. It's an interwoven self-expanding stent. The advantage is it has good radial strength. And it's flexible and durable. So you'll see at the regions such as popliteal, where there are bends and you think there'll be a stent fracture, that's where these stents come into play, where they're actually conform, and you can see it right here in angiography, and they don't break. So usually we'll expect them to be stiff and hard, but the Supera stents actually are very conformable. So they take the shape of the vessel. So that's the advantage. So it, like it says, supports the natural movement of the vessel. And again, the data of their efficacy and the data that they work actually comes from the SUPERB trial, which was mainly comparing outcomes from the single arm from the objective goal. So they followed the patient, and you can see the patency, the freedom from TLR is around between 80% plus. And the problem, like I talked about, is Supera stent, you have to deploy it. You create it. So if you get a Supera stent which says it's a 5 millimeter diameter and a 100 millimeter length, you can actually make this stent from 100 to 150 or 100 to 80, depending on how good you are at deploying it. So that's the disadvantage you have. So they actually did a trial and actually evaluated to see, okay, what happens if I deploy the stent well, which is the middle arm? What if I elongate the stent? It was 100 stent, I made them into 120, or what if I compress it? So the center part gives you the best result, meaning if you deploy the stent at the right length, it has the maximum patency, decrease TLR, decrease complications. If you elongate the stent, that's the worst part. I mean, and if you shorten the stent, the patency rate and TLR go down, but at least it's still better than elongation. So whatever happens, don't elongate the stent. It's mainly about keeping them at the right level. And again, just to give you an idea of how these stents work. And this is how flexible the stent is. Normally, a stent would actually just crack, bend, nick right here, and there's deconformation. Supera, if you click it, it actually keeps the vessel stuff on. So we talked about the primary patency of the SUPERB trial. So the whole idea is in patients who have a lot of calcification, who are at these joint areas, the Supera stent has great data. So sometimes you would want to use the stents, or your attendings or whoever is involved in the care of the patient would probably want to use these stents, especially when you follow them for 3 years and in calcified lesions. I think my time is up. But the whole idea is to be aware about the new technologies, whether it be drug-coated balloons, drug-coated stents, and the indications of where to use, where to not use. And of course, following them up clinically is the most important aspect. Just to give you the last 2 points, we'll always ask, okay, I'm putting a drug-coated balloon, drug-coated stent. What's my antiplatelet regimen? You know, you load you're in the cath lab, or you're outside as a nurse or a PA or an NP in the clinic. And coronaries, everybody knows, 6 months, 1 year, depending on how it is. You had an acute MI, at least 1 year per guidelines. Stable angina, nowadays, shorter is better. 6 months sometimes. You can get the patient off depending on what the stent is. In drug-coated balloon and drug-coated stents for PAD, there is no clear-cut guidelines. It's all hearsay, so to say. There are no trials to prove how long, how not. So usually the rough rule of thumb is, everybody practices differently. If you use a bare metal stent, 1 month of aspirin and Plavix is enough, and then you can put them on for aspirin. If you're using a drug-coated balloon, some people do 1 month of dual antiplatelet, some people do 3 months, that's more than enough. When you do drug-eluting stents for peripheral arterial disease, then they usually go from 3 to 6 months. So let's say a patient comes in, for some reason you put a stent in, now has a gangrene of the foot or needs some dental work, and it's 1 month, you're bare metal, you can actually stop it and don't worry about it. So those are certain points to consider about dual antiplatelet therapy in stenting. All right, perfect, awesome. Thank you.